You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast with myself, Ryan Walker. In this episode, I'm speaking with Robbie Lendrum on myocardial hypoperfusion and injury and trauma. So what I wanted to do in the conversation is examine a couple of concepts which are actually fundamental to how we may approach trauma in the pre-hospital environment. And that's around the Windkessel concept of pulsatile flow into constant flow, looking at this concept of reservoir pressure as an analogue of diastolic pressure, also looking at coronary perfusion in diastole. So we also want to do is explore blood pressure targeted intervention, also maybe some of the disparity between non-invasive blood pressure and invasive blood pressure, the precision of diagnostics versus intervention. We also want to do is look at the concept of bringing forward intervention when it's most needed, and also looking at individually patient-centered intervention. So to do this, I have Robbie Lendrum with me. Robbie is a consultant in cardiac anaesthesia and critical care. He's also a consultant in pre-hospital care working with London's Air Ambulance. He's also a honorary senior lecturer at Queen Mary's University in London. And he is an endovascular resuscitation researcher within the UK. Welcome, Robbie, to the podcast.
Thanks, mate. It's great to be here.
Robbie, if I could get you to start by just speaking to why this is such an important area to focus on.
Yeah. Well, I mean, I think there are a number of reasons why we, as a group, think this is an important area to focus on. But I think fundamentally it comes down to a number of key things. I think, first of all, is the concept of, or the reality of early death following injury. So we've known now in our own data set from really more than the last 10 years. Zane Perkins, one of our colleagues, looked into this in patients with vascular injuries and shock presenting to the Royal London. And in that cohort of patients, at that stage, it was evident that 40% of patients with injury, vascular injury and hemorrhage, were having, exsanguinating before they reached hospital or immediately on arrival, before any opportunity for intervention. And really, since that point, that has been demonstrated in a number of different healthcare systems, populations, that if you're injured and you ultimately die, you tend to do so quickly. So a peak death rate of around 30 minutes is fairly regularly demonstrated throughout the world. So I guess, firstly, as a result of our desire to understand this better, specifically the pathophysiology responsible for this early death, and therefore to be able to look for opportunities to intervene. So I guess that's the first kind of key reason. The next, I think, is this, as I've described, this concept of early cardiac injury or myocardial hypoperfusion and cardiac dysfunction. And I think this comes, from my perspective, from a number of aspects. Firstly, as a result of observation, I'm sure you can potentially relate to this. A large penetrating trauma is the most common cause of injury that we see as a pre-hospital team. And we've been observing for a while patients who are, the junctional groin stabbing is, I guess, a classic example here. Stabbed in the groin, seem to be able to stand up or run for a short period of time, often only seconds before collapsing. So not in a context that you would think would be just explained by volume loss and low preload. So something else seems to be happening to cause this collapse. And obviously that's quite hard to pick apart, but it's just a feeling I've had and others have had for a while. But also, now we have other data sets, and I think you've spoken to Zane about his resuscitative thoracotomy data set. And in that group, so this is patients having a pre-hospital resuscitative thoracotomy following injury. In the group who have exsanguination, so that don't have tamponade, the time from injury to arrest is 40 minutes in that cohort, so super, super rapid. But if you have an intervention to sort of resuscitate the heart, or in this case resuscitative thoracotomy at the point of arrest, survival is already only 10%. And if within 5 minutes that drops to 0, so we have this group who seem to have hearts which, once they stop, they're unresuscitatable. So they've suffered some profound hypoperfusion prior to that point, which is in contrast to the tamponade group who, if they have a thoracotomy at the point of arrest, 60% of those patients survive. So there's something different happening between these two pathophysiological mechanisms. And on that note as well, we also have recent data from a study by Rich Carden looking at over 1,000 consecutive trauma patients presenting to Royal London. Half of this cohort, about 500 patients, end up in critical care. And in that group, a third of these patients have cardiac dysfunction as by a SOFA score domain in the cardiovascular setting, parameter 4. But of those who died in the ICU, 80% had cardiac dysfunction. So, obviously this is a spectrum. We've got this group of patients who die very rapidly with unresuscitatable hearts to this group who then make it to hospital, but within the first 24 to 72 hours die, and the vast majority have cardiac dysfunction. So something's happening in the early post-injury phase to cause that. And then finally, the final kind of thing which has led us to focus on this is we've been putting arterial lines into patients in the pre-hospital setting for a number of years now. We've got about 140 patients in that data set now. And we've been observing this group of patients who have wide pulse pressures in the context of hypotension. So weird blood pressures of sort of 70/20, for example. And my understanding when you lose volume was always that you vasoconstricted to maintain blood pressure. Your preload falls, stroke volume falls, and your pulse pressure narrows. Yet we've got this group of patients who appear to be bleeding and hypovolemic, we think, yet they have a wide pulse pressure. So there's something physiologically that doesn't quite make sense. And we think all of this is linked. So, early death, early cardiac dysfunction, and potentially pathophysiological signals that can direct us at these patients. And that's really I think the key three things that have focused our interest on understanding this better.
Something I'd like to drill into, and I think we'll do it a little bit later in the podcast, is around this diastole and the perfusion of the heart and diastole, and actually maybe looking at diastole rather than the systolic. So looking at, it's always been focused on this systolic blood pressure. You targeted intervention. What's the systolic? Is it below 90? Is it above 90? Is it this? Is it that? And actually, redressing the narrative actually could be truly powerful. But before we go there, Robbie, could we just look at the Windkessel concept and maybe what it does for our physiology around this pulsatile flow into this constant blood pressure?
Yeah. So the Windkessel translates into the air chamber, and this was a physiological theory derived by Otto Frank in the 19th century. And essentially, his theory describes the function of the thoracic aorta, and essentially converting, pulsatile flow into relatively constant flow at the tissue level. And essentially, like the fireman's hose and the air chamber, or the Windkessel, that would turn the pulsatile flow from the pump into constant flow at the end of the hose, the thoracic aorta essentially does the same thing. So you have blood ejected during systole against the resistance, so systemic vascular resistance, which generates pressure, which then stretches your thoracic aorta, effectively storing potential energy. So the aortic valve closes, thoracic aorta recoils, generating diastolic blood pressure. So that was his theory, but the issue with Otto Frank's theory was it didn't really explain what happens during systole. So the measured aortic pressure that you can imagine, your early peak in pressure, the dichrotic notch, and this long tail of diastolic blood pressure. His theory didn't really explain what happened before the aortic valve closed. So as a result, the wave theory, which was the Windkessel concept, the reservoir theory, my apologies, which was essentially Otto Frank's Windkessel, was largely replaced in the 1950s by something called the wave theory, which really relied on the the notion of antegrade and then retrograde reflected pressure waves being responsible for the measured aortic pressure. But the problem with that theory was it had to you had to essentially discount aortic elastance, or that capacitance. So it assumed the aorta was a rigid tube, which obviously it isn't. And it didn't really account for diastolic blood pressure. So only really in 2007, a guy, Wang, his team, and Davies et al. Managed to mathematically separate this and establish the way these different components contribute to measured aortic pressure. And essentially, it's a combination of the two. But the key thing is diastolic blood pressure is really generated as a result of this of the reservoir model, or the Windkessel concept. This concept of charge and then recoil creating diastolic blood pressure.
So just looking at the concept and of this reservoir pressure and creating this diastolic blood pressure, this like you said, this recoil, this elasticity as it comes back, could you maybe speak to how that feeds into sort of coronary perfusion? Because in essence, we're sort of negative pressure beings. We breathe under negative pressure, and that facilitates a venous return. There's lots of different pressure differentials in the body as we are operating under normal circumstances. One of the things about trauma is it quite quickly reverses what's taken the body 10, 15, 20 years to adapt to under negative pressure, and indeed diastole feeding coronary perfusion. Could you maybe speak to how that feeds the heart, and indeed how that can be affected maybe under trauma?
Yeah. So it's super interesting. So I mean, obviously, none of this physiology is particularly new, but I think viewing it from this perspective is really new and really interesting. I think potentially in the future, really important. So coronary perfusion, the coronary blood flow. So the heart's unusual in that it receives 75% of its blood supply during diastole. And it's unusual because it has to function to provide itself with the oxygen delivery it needs to function. And essentially that is because, focusing down on coronary blood flow and coronary perfusion per se, because coronary blood flow is dependent on coronary perfusion pressure, which is the difference between your aortic root pressure, where the coronary ostia are, and the left ventricular pressure, which is related to LV wall tension. But the gradient between the two, the coronary arteries are in the myocardium, generates coronary blood flow. So during systole, when left ventricular pressure is higher and the LV wall tension is high, effectively the perfusion gradient or pressure gradient is less. So in diastole, when the aortic valve is closed and you have aortic pressure in your root, which is as a result of recoil of the thoracic aorta, and the left ventricle is relaxed, you have a pressure gradient. So if your measured diastolic blood pressure is 60 and your left ventricular end diastolic blood pressure is next to 0, you have a pressure gradient of 60 millimeters of mercury, which then results in coronary and myocardial perfusion. That's how you perfuse your heart. In terms of what might happen when you injure an elastic artery, so not necessarily your thoracic aorta, but a hole somewhere in your arterial tree, probably even as far down as your femoral arteries or below. The theory that I think we have and we're working on at the moment in terms of the clinical relevance is, so when you during systole, if you have a hole in the system, the resistance so you're ejecting blood against is effectively lower, so you generate less pressure. So there's less stretch of your thoracic aorta, less potential energy is stored, but also crucially when the aorta recoils, because if you've got a hyperdynamic heart, You've still got some preload. You're going to have some thoracic aortic stretch. But when it recoils against a system with a hole in it, so the resistance it's recoiling against is less, the pressure you generate during diastole will be less. And obviously, from the heart's perspective, if you therefore fail to generate diastolic blood pressure, you've got a problem with regards to coronary perfusion. And the analogy, and I'm sure it was Zane, this was Zane's analogy, which I think sums it up well. It's like trying to blow a balloon up that has a pinhole in it. You can't do it. It's difficult. So I think that's how, the theory is that, if you have a hole in your arterial system, you cause the arterial pressure reservoir to not able to function properly and therefore generate diastolic blood pressure and therefore potentially impact coronary perfusion.
So just looking at this concept of widening pulse pressures and like you said before, around sort of respectively coronary perfusion becoming sort of a lot really impacted by this sort of widening pulse pressure, and indeed by a significantly reduced diastolic pressure. Could you maybe speak to how that affects your practice and or your decision making, either from just looking at the diastolic pressure or indeed looking at the heart rate and the diastolic pressure?
So I think it's probably important to say before we go on to that if you have severe aortic regurgitation, you can have a wide pulse pressure, right? And it's not, if patients have a severe acute aortic regurgitation, they can get heart failure from a number of reasons, but they don't necessarily immediately develop myocardial ischemia. Okay, so I think it's worth just talking about coronary perfusion to try and understand that a bit better. So there's some really interesting work from Johnny Morrison's group. He's a trauma surgeon in Minnesota, who's originally from Scotland, but he's done some work in a large animal model of hypovolemic shock, so pigs who are hypovolemic, but not with uncontrolled hemorrhage, crucially. And what he's shown, and they dissected out the left main coronary artery in these pigs and had flow probes on these pigs. And what he shows in this model is that actually during systole, okay, so you've got hypotensive pig with low aortic root pressure. In systole, you actually get retrograde flow in your coronary arteries. The flow goes backwards, okay? But in this model, you still have some diastolic perfusion because there's no hole in the system. So if you imagine somebody who has both profound hypovolemia, because remember, it's, although we're talking about diastolic blood pressure failure, obviously these people with an arterial injury bleed a lot as well. So hypovolemia is the other key component. So if you have hypovolemia in systole, because your LV wall tension goes up and your root pressure is low, you actually get retrograde or backwards flow in your coronary arteries. If you then get rid of your means of generating diastolic blood pressure, you can imagine how if you've got flow going backwards in systole and no real diastolic blood pressure, really from the point or very shortly after the point of injury, you're going to have virtually no coronary perfusion. So even if you have a young, healthy heart up until that point, it's likely that you can get profound myocardial ischemia within minutes or even seconds of that injury occurring. So to come back to your question, which was, how does this, I think, understanding inform our clinical decision-making about understanding that given there are this group of patients that die super quickly within 14 minutes or survive the hospital and die of cardiogenic shock, the key management principle in patients at risk of this is to restore coronary perfusion by allowing the aortic pressure reservoir to function again. And that probably in a certain group, this group of patients who are at most risk, involves separating that defect from the system somehow, combined with rapid restoration of circulating volume or preload, which obviously these patients are going to have an issue with as well. But as a concept, that addressing that pathophysiological problem related to coronary blood flow is key, and it's probably, although volume replacement is fundamental to that, it's probably a group where that isn't going to be enough.
So, Robbie, could you speak to the significance of the first 72 hours after injury?
Yeah. So this is really important, I think. So so we know that patients who get to hospital and then die in the ICU, 80% of them have cardiovascular dysfunction. And we know from Zane Perkins' data that there's this group of patients who, rapidly get cardiac dysfunction with hemorrhage and die within 14 minutes. So there's clearly a spectrum here of patients who die very rapidly from cardiogenic shock and failure, because that is the endpoint of dying effectively. And then there's this group who make it to hospital then develop cardiogenic shock and die. And I'm sure many of your listeners can relate to the patient who both dies on scene very quickly, but also gets to the operating theatre, has a laparotomy, gets hemorrhage control, and then continues to just deteriorate despite volume transfusion and vasopressor infusions. The lactate's going up, potassium's going up, patient becoming more hypotensive. Somebody eventually does a thoracotomy because nobody can think what else to do. And there you have a 20-year-old man who's got a massively dilated, poorly functioning heart and cardiogenic shock from something that's happened in the hour or two prior to that. So I think in that context, that if you look, Max Marsden, who is a surgical fellow who's part of Camboy's unit at the Royal London, he's published an extremely important paper called Trauma Laparotomy in the UK, Prospective National Service Evaluation. And this looked at over 360 patients who had a laparotomy, emergency laparotomy. And if you look at the group in this study who are hypotensive on arrival, code red patients, who go to the operating theatre within 90 minutes. In that group, over a third of those patients still die. And in that study, the average time from injury to the emergency department is 74 minutes. The time from emergency department arrival to knife to skin is 65 minutes. So in the UK, if you're injured, code red patient who effectively goes straight to theatre, that takes over 2 hours, takes about 140 minutes. So if you bring all that together, you've got a bit of a problem. And really, I think it's clear that cardiogenic shock or cardiac dysfunction is killing these patients, but something is happening in the immediate post-injury phase to cause that, whether you die very quickly or you make it to hospital. And that's why, really, if we're going to understand and address that, the resuscitative intervention has to happen in the pre-hospital phase. There's probably not much point waiting until you get to hospital. If you're going to, do things like rebuild or, sustain thoracotomy in specific patient groups to try and address that problem, it probably has to be pushed out towards the point of injury. If it's going to have, if we're going to manage to impact upon this problem, in terms of the time it takes to get definitive treatment and the time and that concurrently during that time, these patients are getting, cardiac injury and cardiogenic shock.
So let's talk about that, Robbie, because I think this is a key concept. I've got a few other questions I'm going to ask, but I'm actually going to drill down into that because I think that's such a fundamental answer you gave there. So and the key concept and question I'm going to ask is around why is early femoral access such a necessity in shocked patients as a function of maybe of pushing or indeed retaining blood, either in zone 1, zone 2, zone 3, but retaining blood in that sort of thoracic artery as a means of restoring or retaining coronary perfusion pressure?
So I think, early femoral access is something we've been doing for a while now. Really, it started as a bridge to REBOA. So patients who perhaps didn't warrant immediate intervention with REBOA, but might do in the future, we get femoral access so that could be exchanged for bigger sheaths to do REBOA if required. But it, I think, has evolved slightly in terms of, we are doing that in more patients for a number of reasons, to monitor them more closely, to adopt that cardiac critical care approach because of issues with non-invasive blood pressure. But I think my hope is that, once we understand this problem and its relevance, I guess, more clearly, perhaps, getting early femoral access will allow us to identify high-risk pathophysiological patterns like this potential pattern of a wide pulse pressure, to therefore allow us to inform decision-making and then target the group you described with aortic pressure reservoir failure, risk of early cardiac injury, myocardial hypoperfusion, be able to direct resuscitative intervention at those patients more easily, because as you and I'm sure many of your listeners can relate to, our interventional capacity is increasing, but knowing what to do in the heat of the moment when there's a lot of pressure on you is super tricky. And I guess my hope is that we can combine this kind of monitoring, vasopressure monitoring, with deep understanding of these pathophysiological signatures, combine that with machine learning to therefore inform decision making. Because when you're standing in the back of an ambulance looking at a patient who's been stabbed, London's slightly different perhaps to other systems, but trying to decide, right, well, I'm 10 minutes from a hospital, we can be in the research room in 15 minutes. We've got this patient who is profoundly shocked. Is this someone that would benefit from a team spending 10, 15 minutes plus on scene, not going to hospital, to ultimately derive benefit? And that's what we need to be able to understand at the moment, because at the moment a team will get in an ambulance, patient's been stabbed, or in an ambulance, they have literally seconds to try and assimilate all this information with regards to trajectory, clinical findings, hemodynamics, and then make a decision about what to do. And it's almost impossible. So we need to be able to pick the patients that are at high risk, to therefore be able to direct the interventions which are also high risk and time consuming at those most likely to benefit.
So you said a few really interesting things there around AI modeling, and I actually want to come back to that actually and just drill down into that, because like you said, we could actually get some of the software to do the heavy lifting for us regarding pattern recognition. But before we maybe just drill down onto that, you also said something around Zane's work. And one of the things I took away from the interview with Zane, and just obviously speaking to yourself and Zane, is that the research is informing us that there is these two separate disparate groups. There's the exsanguination group and the tamponade group. And they are almost have to be treated as two entirely different separate pathologies. And the exsanguination group are almost this one-way path to the heart really not recovering. We were just speaking offline, Robbie, about how Zane's work has informed your practice about bringing forward critical intervention when you see the tamponade, when you see an echo with blood around the pericardial space. Could you maybe speak to just to that and how it shifted your thinking?
Yeah, so that Zane's work, which I think you examined on the podcast, is hugely important and changing practice, I think, already in terms of a number of aspects. But I think the concept you mentioned there of the survivability window, it is very important. But although the two, and I probably won't, I mean, we could go into this, but the two pathophysiological problems are different in that, as you say, if you have no detectable cardiac output, traumatic cardiac arrest with tamponade, often you can still see, if you put the echo probe on a heart that's moving, it just can't fill. And we have survivors from tamponade whose hearts have stopped, as an asystolic and a resuscitatable. Whereas, as you say, with the exsanguination, once the detectable cardiac output is lost, really, there are a few survivors within the first 5 minutes, but no one survives. So although they're different, and that's what I think this type of understanding of pathophysiology helps us separate out, as in the patients with exsanguination or arterial injuries. I think one of the reasonable explanations of this is that they are much more ischemic much earlier, resulting in the problem you defined. But the end point is the same in both groups. Ultimately, the patients go from a sinus tachycardia to a sinus bradycardia, a slow, broad, complex rhythm to asystole, although it happens more quickly with exsanguination. So I think the key principle that brings them both together is that you have to restore coronary perfusion before the heart reaches that point of decline. In somebody with tamponade, this sort of PA group, you have a bigger window of opportunity, whereas, as you say, when you lose a pulse, or you have traumatic cardiac arrest with exsanguination, it's too late. But I think the key thing that brings it together is that decline, and you have to restore coronary perfusion before that is established. I think the challenge is, if you now focus on the exsanguination group, we know that once they've arrested, it's too late. But then you have a patient before that who's not arrested, so they're not dead. And the key challenge is knowing which patients to, intervene with, interventions like resuscitative thoracotomy or zone 1 Rabo, which are, invasive, risky, time-consuming. So that's the challenge. I think it's clear that these interventions benefit patients in certain circumstances, but identifying them in the exsanguination group and knowing what to do and when is key. So that's why I think understanding the pathophysiology to inform our decision making, rather than it being going, we'll just give volume and run to hospital, and then then there's a percentage of patients that we know will not survive. But so if we're going to deal with that and generate the next generation of survivors, we need to be able to intervene in those patients who aren't dead in the immediate post-injury phase.
So let's just drill into some of the diagnostics, actually, because I'm consistently surprised at how disparate and varied NIBP can be with invasive blood pressures, and just the actual difference in measurements. And looking at, as we've spoken to before, the utility of ultrasound and the utility of ETCO2, of ECG, and actually what we're doing, like you said, is it's really difficult in such a short space time, because the window is finite, it's quite narrow. But could you maybe speak to how AI might be able to help us in this, because there is pattern recognition in this, and the more sensitive we can get the diagnostic markers and triangulate or bifurcate the markers and push them into an algorithm, well, hopefully we can start to get a more sensitive picture. I know Zane speaks to these Bayesian analysis and Bayesian systems to help us differentiate that. Could you maybe speak to that from your perspective?
Yeah. So that has to be the future in my eyes. We even in a system in London where you see high number of these patients, and with years of experience, nobody, I don't think any of my colleagues would say that it's easy. Perhaps if you've got someone who has a hemopericardium, who's been stabbed in the chest, who has become unconscious in your presence and has a sinus tachycardia, we now know in that group of patients, you basically have a 10-minute window. So it's fairly, I feel now confident that you're doing a resuscitative thoracotomy, the pre-hospital setting is the right thing to do. But when you have a patient who is bleeding, who is at high risk of dying of cardiac dysfunction in the pre-hospital setting, or if not that, within the first 72 hours, trying to decide, well, do we do rebolt on this patient, or will they survive the hospital, the blood transfusion, or if we do that, they might get to hospital, will they die 24 hours later? That is super complex to pick apart and figure out what to do. And we have a platform in our cardiac operating theatre now with technology that has a hypotension prediction index. I don't mention any manufacturers, but essentially it uses AI to create an algorithm which predicts hypotension in the context of cardiac surgery, which obviously cardiac surgery has loads of variables affecting blood pressure, and it's able to detect from pulse contour analysis and other functions and predict an outcome. So to me, it seems reasonable that we now we have increasing data sets involving patients with arterial blood pressure monitoring, that using that kind of technology to predict the risk of early cardiac injury does not seem unfeasible. And then, potentially this type of invasive, infrequently required resuscitative care might be more accessible to services that don't see 5 stabbings every day. So I think, to me, that has to be the future. I don't see how we can move forward really with this type of care, asking clinicians to just rely on, trajectory, clinical examination, and physiological interpretation. I think in 10 years, if we're still doing that, we will have failed massively.
So, Robbie, as we're starting to come into land on the conversation, just a couple of more questions, if possible. One would be so should we be tailoring our treatment more to individual diastolic blood pressures? Or how do you see, I suppose the wider question really is, how do you see individually patient-centered intervention looking in the future?
Yeah, so I think you're right. Based on, I think we've got a fairly compelling rationale for a mechanism for early myocardial injury and hypo-perfusion. So therefore, if that's the problem, targeting diastolic blood pressure, which is the determinant of coronary perfusion, seems reasonable. We're all used to looking at systolic blood pressure, as you say, but actually probably diastolic blood pressure would be a better way to do that. And if you look at if diastolic, if you look at the swine models of coronary blood flow, really below a diastolic blood pressure of 50, so therefore coronary perfusion or coronary perfusion gradient of around 50, coronary perfusion tails off massively below that point very rapidly. It can't auto-regulate itself anymore. It becomes pressure dependent. So targeting that seems reasonable. And I think, we're going to report on this in the next couple of months, but we've shown in a study we're doing that in patients with low diastolic blood pressure, if you do zone 1 reservoir and the heart's functioning, immediately the diastolic blood pressure within seconds jumps. So once you separate the defect, allow the pressure reservoir to function, you have this immediate jump in diastolic blood pressure. So we potentially have a means of restoring coronary perfusion in those patients. But yeah, in terms of the individual patient, we need to understand, as we've talked about, which patients to do that in. So if we're really going to deliver patient-centered precision kind of resuscitative care for the individual, key things are we have to be able to identify that high-risk pattern and also have validated it. So yeah, it's fine us talking about that, but we need to link this all up to show that these patients are developing cardiac injury and myocardial dysfunction. And we've got evidence of that in terms of small cohort study looking at HFAB in patient, which is a heart-specific fatty acid binding protein. So it's a marker of myocardial ischemia that increases very early after injury in a cohort of patients with hypovolemic shock and arterial injuries, as opposed to venous injuries in the control. You have a much bigger spike. Rich Carden's work that we talked about earlier shows patients who are injured, who die in ICU, have high evidences of cardiac dysfunction. So we're starting to head along that path, but really we need to, validate and connect those two things so that we can therefore identify it and then deliver interventions to the individual patient that restore coronary perfusion.
Could you see, as a function of an impending critical care team to a patient who's had a massive injury load, albeit blunt, or indeed maybe even penetrating, the team are maybe still 5 or 10 minutes out, it may or may not be in London, but could you see early femoral access being a function of a critical care practitioner and or critical care paramedic to get the access in readiness for sort of selective aortic arch perfusion? Would that be something you would see as an adjunctive and or supportive intervention for a team delivering a Roboa type intervention?
Yeah, it's an interesting point. I mean, I think selective aortic arch perfusion is a sort of slightly different intervention, but focusing on the concept of a critical care paramedic putting in an arterial line, I think that's totally feasible. I mean, I think, where do we go from here? Informing decision-making, allowing planning at an early phase, if it doesn't seem too far in the future, if you've got a team treating a patient who have an ECG on, you can put in an arterial line to be pushing that information forward towards an even more enhanced resource. To therefore allow planning, preparation, decision-making to be happening en route. I think that very much would be a feasible and useful way to proceed, to get as much physiological information fed into another clinical team or a decision support platform, to make sure everything's happening as quickly as it can be. Yeah, totally.
Yeah, I think with the utility of sort of POCUS or point of care ultrasound, it becomes, I think, a lot more reasonable and or achievable when there's highly trained critical care paramedics who might be available to do both the preceptorship training and indeed sign off in early femoral access. I guess yeah, as we come into land, Robbie, and just look at some salient take-home points from this conversation, you mentioned some fantastic concepts all the way through this interview, actually. And it's a real, like you said, it's a real game changer, because what it's doing, it's flipping on its head probably the archetypal teaching of always track systolic blood pressure, think about brain perfusion, think about plugging the holes, refilling them with fluids. And actually, this is far more nuanced. This is far more looking at very different values and a very different trajectory, bringing forward intervention based on pathology, and like we said before, very much patient-centered intervention. Could you maybe speak to a few salient take-home points for listeners as we close?
So I think we need to shift our mindset and really start to consider that the patients who die in the first few minutes to the first 72 hours do so largely and almost irrefutably because of cardiac injury and then cardiogenic shock or cardiac dysfunction that manifests itself within that spectrum we talked about. And I think, we've got some, I think we're making some interesting progress here and we're onto something, but it's early days. Yeah, it's early days. I mean, we've got a lot more work to do. But really understanding this physiology and pathophysiology, and therefore allowing us to identify high-risk groups and target it in an individualized way with precision for the individual patient has a lot of potential to try and mitigate and prevent this from happening, and also when it has happened, instigating, even further down the line, things like selective aortic arch perfusion and ECMO, which we're, having actually a fair amount of success with in the context of trauma and in certainly within Bart's Health at the moment. Allowing us to produce the next sort of generation of survivors. But really that it's time to move on from, the sole treatment for somebody who's injured and shocked being, give them a blood transfusion, drive and fly faster, and try to stop the bleeding as quickly as possible. Obviously, these are fundamental to managing these patients, but we know that it can't be the sole means for managing these patients, because despite all that, we have this group of patients who continue to die in the immediate post-injury phase within the first 72 hours. But it's more than just bleeding, blood pouring blood in while it pours out. We need to move forward with this type of cardiac critical care approach. But, really, and this is a challenge for everyone, is that, we need to identify these pathophysiological high-risk features so we can identify these patients prospectively, because it's very easy going, oh, here's 1,000 patients, 80% of them had cardiac dysfunction. We need to do something about that. It's easy in retrospect, but the challenge is prospectively identifying them so that we can direct this sort of type of, resuscitative care. And by that, I'm talking about, reboa, thoracotomy, mechanical circulatory support at those most likely to benefit. So I think they would be the key salient points.
Robbie, thank you so much for your time today. I really appreciate it.
No, I mean, thank you for having me on. It's a real honor, and I'm very grateful for it.
Listening to the Pre-Hospital Care podcast on the Medics Academy Network.